Good morning. Welcome to our first concurrent session of day 2. I'd like to welcome Stephanie Aguilar and Chelsea Cook, who will be speaking about Help Me, Help You, BIPOC women in behavioral health through research, resource, and experience. Stephanie Aguilar is a licensed mental health counselor and an approved state supervisor. She is also working toward becoming a child mental health specialist, an ethnic minority mental health specialist, and a disability mental health specialist. Stephanie earned her MA in clinical mental health counseling from Gonzaga University and her BA in psychology from Eastern Washington University. Stephanie has been a mental health counselor in a variety of settings, and she is currently the outpatient clinical supervisor at Triumph Treatment Services in Yakima, Washington. Chelsea Cook earned an MA in counseling from Northwestern University and is currently working as a mental health service provider at a women's intensive 28-day inpatient treatment center in Yakima, Washington, leading dialectical behavioral therapy skills group and conducting assessments and diagnosis. Additionally, she has certification in Illinois for administering alcohol and addiction counseling, and after working for 2 years at an outpatient methadone center as a case manager and substance use disorder counselor. And now I turn it over to you, Stephanie and Chelsea.
Thank you so much, Danny, for that amazing introduction. And so also too, we will be starting the presentation. And of course, we are going to describe ourselves a little bit. So I'll actually let Chelsea kind of take over.
Okay, so hi everyone. Happy Friday. We finally made it to the end of the week. My name is Chelsea. And just to give a description so that you all know who is presenting today, I have my hair up. We're both in the same room, so that might help. I'm wearing a white shirt with a gray vest, and I have black hair, and I'm Asian.
All right. And then also too, I am Hispanic. And so we will kind of get going with our slides too.
Okay, so Danny already sort of introduced our presentation for today. This is the agenda that we'll be following for today's presentation. So we'll really be reviewing the desired objectives and goals, assess different terms that are important to our topic, which are bulleted here on the bottom. Different studies and literature will be looked at as supporting evidence regarding BIPOC challenges in conjunction with exploration of our personal identities. So me and Stephanie's identities as well. We'll also be going over resources that are available for both providers and clients, implications for best practice, and we will also be welcoming questions. Hopefully there's enough time, questions and an opportunity to connect at the end.
All right, and then continuing on, these are kind of the goals and objectives for our presentation. And just like Chelsea had pointed out, we are going to go through extensive research with this. There are going to be times where we are going to go really fast through things, or of course, right, there may be points where we actually just graze over things, but you will have access to the presentation. So of course, you'll be able to actually look at all of those things a little more in depth if you would like. We also, again, will go through our own personal experiences and how it really relates to this topic. And then also too, we will be going through some really creative either coping skills or also to resources that you can use either with your clients or also to for yourself.
Okay, moving on. So list of terms. Since there are so many terms that we would like to cover, I've organized them into these 3 sort of distinct categories. So here we have labels that are typically used or terms that are used when addressing systems and models, terms that are more so prominent within culture and society in general. And then finally, the third category is terms that are typically used when addressing behavior. So the importance of context. Our experiences are shaped by our lived experience, which occur within a multifaceted reality. So these domains that we live in, such as, within our family, our neighborhood, our society, all are cohesive factors that create how we view the world and ourselves. And this could not be more true for those of us that come from different backgrounds. So as you can see, I sort of made a little visual, the individuals in the center, the community systems, which then make up the schema or how one views the world in themselves. So terminologies across these three major domains, which coexist, like I said, and they come up to create the individual's experience. And I just want to highlight that BIPOC women behavioral healthcare provider challenges are distinct, and that distress and barriers are consequential of those three domains that already are, inherently biased and racialized with stereotypes and identity assumptions, and which then leads to impacting one's psychological flexibility. It can increase levels of chronic stress and burnout, especially for BIPOC women. So just kind of differentiating that with an idea of context. I want to start off with defining what a system is, and this is how I've operationalized it. So what is a system? It can be defined as a boundary that dilutes complexities of a chaotic external environment through separation of recognizing patterns among parts that interact or impact one another. So this idea, and you can see a visual of it here, this was introduced in the 1940s and 50s by biologist Ludwig van Bertalanffy. He created general systems theory, which you can see here as sort of a means to understand how living things operate within nature and life. So looking at the chart here, the object exists in an environment which influences input, where it gets processed, producing a different output, thus creating a cycle. This cycle is what he wanted to explore and to better understand how context impacts the subparts of a living system. Cybernetics, developed by Albert Wiener in the 40s, is a different theory that was established as a way to understand communication and feedback as means to maintain sort of a homeostatic state. So he was really looking at how an organism maintains homeostasis. So general systems theory is more open and more context-based. Cybernetics is more about communication and feedback loop. There's several different waves of this theory, but we're not going to get into that due to time. And I would just like to point out that while both theories were introduced within the field of science and mathematics, these theories have been extended and are pragmatic towards framing other topics such as politics, art, and psychology. Many of you may know this, especially for those of you who are counselors like Stephanie and I, but the sort of historical roots of psychology are embedded in sort of a very racist model. So when this model that is often addressed or used within counseling comes up, it's actually very dismissive of different lived experiences as a result. Not only that, sort of the assessment and diagnostic processes themselves can be also limiting. It treats the client and client issues as static, when in reality, a lot of things happen for a lot of different people. Our situation and our reality and our context is very dynamic. And Bertalanffy actually says in his book, General Systems Theory, that concepts and models of equilibrium, homeostasis, adjustment are suitable for maintenance of systems. However, it is inadequate for phenomena of change, evolution, creativity, and self-realization. So we'll see, how he highlights that it's really important to address context when addressing an issue or an organism. Okoro, Omaro, and Ray did a study sort of looking at health outcomes and accessibility of services. And this is what they said in this study. Quote, among the advanced healthcare systems, the US healthcare system, though exceptional in its achievements, has barely kept up with the changing demographics, which in turn has led to disparities in access to treatments and treatment outcomes. So I'll let you sit with that for a minute to think about that. Typically in Western healthcare, we see the biomedical model being utilized. And while it is good that we utilize this model, I think, again, it treats the client as stagnant or their issues as static, when in reality, there's so many other different services, unique services that are more culturally embedded and acknowledging that can be integrated within the administration of services as well. So unique services that exist outside research-based homogeneous interventions, such as doulas and traditional Chinese medicine, symbolize the importance of integrating individual, family, spiritual, and generational values when providing health-related services to the community. Transitioning now to different models. So like I've been saying throughout the presentation, the biomedical model or the Western model of medicine, I've created a Venn diagram here to help really illustrate the differences between this and a more holistic or integrative model of care. And just an FYI, there's a monitor over here. So excuse me if I'm looking at, at two different places. So the Western model of medicine is allopathic, which means that it's a branch of medicine that typically intervenes with things like drugs, radiation, surgery, and those kinds of services when treating illness. It's reductionist, which means that it treats contributing factors of illness or disease as separate. And again, this model has a preference of utilizing research based and scientific backed treatment, whereas a more holistic or integrative model of care, while these concepts are still utilized, they also include experiences and values and cultural backgrounds when providing care services. This model recognizes that healing is multifaceted. It's not just about physical ailments, but also introducing how mental and spiritual healing can take place as well. Outcome is more client centered due to this, and this model focuses on the complexity of evolving factors which impact the client and how they're present. Another visualization of the two different models, figure A is a conventional research and assessment method that is typically used for Western medicine. As you can see here, it's more of a step-by-step sort of process, more top to bottom or bottom to top. In figure B, you can see that the approach is much more integrative and holistic within medicine and treatment. So that is the more integrative holistic care model. You can see that the same topics or the same domains exist in figure B, but that they're much more intact with one another. And I think this is a much more sort of accurate representation of a client or a person when they're coming to you to address stressors, concerns, or symptoms. And this figure was referenced from the Integrative Medicine and Systemic Outcomes Research Issues and the Emergence of a New Model for Primary Healthcare article. This is a literature review of sort of diversity in healthcare services that I found. So a lot of the research seems to concentrate on women, on the research on concentration of women who are BIPOC in low-wage healthcare roles is well established. A lot of literature also covers that BIPOC women primarily occupy the most physically demanding jobs within healthcare, in addition to support jobs. And finally, research states that white women are disproportionately represented in jobs which have capacity for authority or supervisory sort of potential.
Also, to just taking a moment to really reflect if any of these really stand out for you and your agencies, or also too with your practices.
So moving along to privilege and oppression, I'm just gonna kind of go over the historical and social identification of these two words. I'm sure you've all heard them, pretty frequently. I feel like they're sort of a buzzword at this point, but just kind of maintaining accuracy on what these concepts are. So the concept of privilege is first introduced in the beginning of the 20th century by American sociologist W.E.B. Du Bois, who is pictured here in his book called The Souls of Black Folk. And really here, he parses out this term that he calls double consciousness, where he found that a lot of Black individuals, while wanting to retain their own unique cultural identity, were often faced with sort of pressure to adhere to the dominant culture, which is often, one of whiteness. He also observed that white presenting workers gained more social benefits and higher wages versus Black counterparts, despite both coming from impoverished backgrounds. And the last quote there is made by American activist and scholar Peggy McIntosh, and she defines privilege as this, quote, an unearned knapsack of benefits and assets, an unquestioned, unearned set of privileges afforded to white people.
All right, and continuing on a little bit more with definitions and terms, I'm pretty sure all of us have actually heard a lot of these terms, but we're just going to go over them again just to make sure that we have kind of a baseline knowledge. And so we are going to go into Kimberly Crenshaw's theory of intersectionality. And basically, what she was trying to say with this is that we have so many different identities that make up us, and that they don't just exist in isolation. And so she really was able to say that they intersect and overlap, and also too, they create our experiences and also to the challenges that we face. And so Another term that really to kind of look at is critical race theory. And so also to Derek Bell and then also Alan David Freeman, they were actually at the University of Buffalo Law School and they actually looked at what this looked like with studying US institutions and also too with law. And so this is going to be a very basic definition because it's always changing. It was able to look at that again, US institutions and also to policies actually have racism interwoven into them. And so again, if we think about like housing and redlining, that would be an example of that. And also too, we even have it in healthcare access. So also these are just two different figures as well. And so you'll actually be able to see the North Central University diversity wheel. It actually goes through different dimensions or domains of identity, and you can actually see all the differences. This is also another example of, again, going through Crenshaw's just intersectionality term and also to different facets of identity. And I do love just kind of this quote here on how, again, if we look at our power and privilege, it can actually just make up our own unique experiences with discrimination and also to with privilege as well.
Okay, so this is a really interesting study that was done in 2023 by Bergkamp and his colleagues. They really looked at in the study the differences in treatment between white psychotherapists and BIPOC psychotherapists. So we'll really quickly, I'll go over this figure here. The therapist paragon is defined as sort of the ideal state for a counselor. So you'll see that the ideal therapist is regarded as a blank slate. They're very neutral, right? Positive regard, a lot of client empathy, and at the same time maintaining limited self-disclosure. The agent therapist, or the most socially privileged individuals, usually white or Caucasian individuals, they kind of have to dress down when working with BIPOC clients, focus on rapport with BIPOC clients, and the study found that oftentimes the ruptures were blamed on a client's cultural differences. So the study found that multicultural differences were acknowledged through attempts to equalize power instead of having, sort of a conversation about it. The study found that there was a lack of multicultural training during graduate studies. Again, ruptures were justified through a client's readiness or lack thereof to change. So anytime that there was a sort of resistance, the white psychotherapist would just kind of say, well, maybe the client is ready to change, when in reality, there could be a lot of different factors that are impacting the client that might not have been acknowledged in the counseling session. And finally, the study found that the white psychotherapists had a tendency to speak in simple English and limit professional jargon when working with BIPOC clients. So now moving on to the BIPOC psychotherapist experience, we'll see here the target therapist or the marginalized individuals. The study found that they experienced a lot of microaggressions from white clients, not only from white clients, but colleagues as well. And there was a conflict between being a good therapist and personal integrity. So when experiencing that microaggression and sort of going against advocating for yourself for fear of retaliation, but then at the same time, that doesn't mean that that isn't impacting you internally, right? So then there's a sort of dressing up status where BIPOC therapists have to work, significantly harder to sort of achieve the same status as maybe their white counterparts. So Bergkamp and his colleagues report in the study that Black BIPOC psychotherapists experienced microaggressions from white clients. They had much more difficulty establishing credibility with both clients and colleagues. There was a high level of stress as BIPOC providers felt ill-equipped on how to appropriately respond to microaggressions. And the study also found that there was a significant presence of imposter syndrome. So you can see here, there's a huge disparity between services administered as well as how the professionals were being treated themselves. This is just a brief summary of the study. So Bergkamp et al. Determined that the pathway toward the therapist paragon was paved and reassuring for the white subgroup, and however, a source of harm and self-doubt for the BIPOC subgroup. Microaggressions and inadequate therapist training regarding reaction and response to this results in what they called the therapist martyrdom, where, again, like I said, when you experience sort of an offhanded comment, but not wanting to sort of draw attention to yourself, not really wanting to advocate for fear of retaliation. However, at the same time, that continuing to build up is, you ultimately sacrifice yourself in exchange for credibility professional recognition and, to continue staying at the job where you're at. And this has been happening for years. It's not, a new idea. So
Most definitely. And we will go through more concrete examples as kind of our presentation goes on. But before we do want to make sure that, of course, right, we are just making sure that everybody knows kind of at least the baseline knowledge again. And so there was Dr. Chester Pierce who was actually able to coin the term microaggressions. And he was also able to notice just different comments that were being said by his white students to his black students and the impact that it really did have. And so, again, kind of just a simple definition of microaggressions would just be a subtle or unintentional verbal, behavioral, or environmental slight. It does not mean that since it has micro in it, it doesn't mean that it has a small impact. It can actually have a very big impact. And so we do want to just point that out. So also too, here is kind of more in-depth definitions of microaggressions and also to what they can be. And so again, we're just going to go over some examples as well. So again, with a micro insult, this could be implying that a woman of color or also to a person of color or even a person with disabilities, etc., they actually got their job based on diversity or action or quota. And then also to, again, a micro invalidation could be giving credit to the wrong person. And again, assuming that based on their identity, they couldn't have done the work. And again, just another example of micro assault could be again just racial profiling in law, but also to it also happens in healthcare. And so kind of recognizing those things. Environmental microaggressions, this isn't something that we really talk about a lot, but also to maybe some of you've actually seen it. It could be in different healthcare settings or also to college settings, but it is actually looking at lack of representation or also as well, again, just being on a college campus, noticing that a lot of the buildings are actually named after white people, or also to not a lot of just acknowledgement of different diverse people who have contributed to the campus, just different things like that. And also too, here's just some reflection time. Has there ever been a time where you've experienced microaggressions with clients, but also to kind of expanding this with like different peers, staff, etc. And so kind of sitting with that and seeing kind of what comes up for you.
mm,
So also too, we are going to go over some concrete experiences with providers in mental health, but also too, we had to kind of look at this in healthcare since there is just such limited research in this topic. And so just wanting to throw that out there. And so also too, like Chelsea had pointed out before, there is a lot of research that actually notices the impact of microaggressions and also to BIPOC providers specifically. And so with this specific study, they were actually able to look at BIPOC providers' experiences in mental health and what they were experiencing. It was really interesting that a majority of participants actually felt moderate to high levels of stress. Also, too, they reported an increase of racial discrimination and also to feeling race-based stress. And also, it was very interesting with this specific study that they actually noticed that since there was so much stress being experienced by the individuals, that they would actually participate in maladaptive coping. And actually, if you're able to look at the slide, these are kind of the definitions of maladaptive coping that they were able to look at, and they use this with the brief inventory. And so basically, what this research was able to kind of really point out and look at was that there are points where mental health providers are actually practicing in spaces that may actually induce just emotional exhaustion, depersonalization, and reduced personal accomplishment. Again, it is a little bit hard to parse out if we actually look back at critical race theory, if again, mental health providers are actually seeking these things out, or also to if this is kind of more of an institutional or systemic issue. And also too, again, just other things that we've already kind of covered, but also wanting to highlight is that with a lot of these BIPOC providers, they were experiencing just more burnout, more systemic racism, also to racial discrimination, and of course the race-based stress, but also an increase of DEI work and also to DEI mentorship. And so kind of thinking about how there's more stress and then also too, there is more tasks being assigned. And so also we are going to go into a more depth in the, well, kind of more depth definition of emotional labor. And so also there is a lot of different definitions now, but we really want to look at what Hochschild was actually trying to say. So in 1983, she was actually able to coin this term, and she was able to look at kind of three different requirements. And so now it has been expanded, but also if we really kind of think of it at the bare bones, basically emotional labor is just the involvement of managing one's own emotions and also too with the face of another person. And so basically we're trying to manage our emotions while there's another person present. Another way to look at this is really kind of suppressing our negative emotions and also to just trying to present as calm and pleasant when maybe that's not what's actually happening for our world at the time. And so it's also important to note that there is not a lot of research between intersectionality, race, gender, and profession. And so just wanting to at least point these things out there that very limited and we need a lot more. And so here were actually two different studies that were actually just conducted. And what we were able to see or kind of look at is that, of course, with one of these studies, Black women who were in their professions actually reported an increase of having to feel like they had to conform to the organization. And so they couldn't be themselves. They also reported an increase of feelings of loneliness and alienation. And so that was a real eye opener because I think also too for Chelsea and myself, we were actually able to feel that way as well, even in the agency that we're at. Also, kind of looking at what Kathleen Wong looked at, she was also able to notice that, again, providers or professionals that were practicing in predominantly white spaces felt like they couldn't be frustrated or discouraged when they would have coworkers that would display either white guilt or, again, that kind of performative allyship. And so they would actually feel like they couldn't express anything. And then also to, oh, sorry, did just want to point this out. This also was an expanded definition, actually looking at what emotional labor actually takes in. And you'll notice that you only really see gender, but you are not able to see that. Again, race plays a really big role in things as well. And so also too, we did just want to talk about another term, which is racial weathering. And so basically this is similar to erosion or what happens to rocks. And it's the constant stress of being in a systemically racist society. And so it looks at how as BIPOC providers or also to BIPOC communities actually experience higher levels of stress and it actually affects their health. And so this could be different health elements or also to premature aging. And so it really is kind of for one, a really big thing. And also too, it's been studied in a lot of different communities, whether that be again with immigrants kind of coming over or different things like that. And so kind of keeping these things in mind that not only are we having to deal with either microaggressions, but also too, our physical health is actually being impacted.
So Stephanie's discussion and sort of definition around racial weathering provides a good gateway into BIPOC women's challenges in professional roles. Blake Beard postulate that efforts to blend into the dominant narrative risk BIPOC women for becoming chronically invisible within research, medical, and academic settings. This can lead to acculturation regarding BIPOC as well as LGBTQIA plus women, who are constantly confronted and bombarded with navigating a racialized, sexualized climate, on top of that, addressing negative stereotypes and balancing frequent misconceptions. This leads us to the phenomena of jeopardy or double binding, which occurs when two conflicting demands, neither of which can be ignored or escaped, occur. So that is a the idea of double binding is really, really common for those that may have overlapping identities, of which are not the dominant culture. So this really illustrates the harsh reality that BIPOC women, even when occupying higher positions and roles, go through daily. And this is what really compelled Stephanie and I to talk about this, because it's really important to increase awareness. And we hope to do that through this presentation. Not only that, but also helping helping you guys sort of understand how to navigate these conversations and really fostering that willingness to closely examine a flawed legal, professional, and academic system. Studies report that BIPOC women in the sciences experienced more harassment, both sexual and racial, compared to white women, white men, and BIPOC men. So another thing to think about.
All right. And so also too, I do love in the chat, not to say that we're trying to have both. And also somebody just really pointed out a really good point of just rule settings. And that's something that we also wanted to cover during this talk as well. And so actually with one of the studies, there were a lot of interesting things that were noted. And so the biggest thing is that with rural settings, there actually is a lack of specialty, and that could be across the board for anything. So it could be with trauma, but also too, this is bleeding into healthcare as well. Also, too, there is a significant delay with the onset of symptoms and actually being diagnosed or actually getting access into services. And so, again, I know there is a lot of us throughout Washington that actually are able to see that. Again, you might have a provider that's all the way in Seattle, but that is actually serving somebody in Yakima, let's say. And those are very different, just climates, cultures, etc. And so another thing is that if you actually kind of look at the slide, there was a lot of different things that were reported. But one thing that was really just interesting to me was that there was actually a lack of caregiving services or a lack of quality caregiving services. And really, if we kind of think about that, that really does hinder clients getting access to the different healthcare that they need, or also to just actually fulfilling those needs of just well-being.
So rural settings and mental health, just for the sake of time, this just kind of goes, the article just states that rural communities are not monolithic and that it is not a one size fits all sort of solution. Like Stephanie has mentioned, there is a significant lack of specialized care. Not only that, we are currently located in Yakima, Washington, which is a rural city, and there is a significant amount of lack of not only specialized care, but also lack of providers, right? There's not much incentive for maybe moving out to Yakima when you want to go to New York or California. So this article really states that it's really important for positive collaboration to occur, not only between formal providers, but informal providers as well, in order to provide a more holistic service for those in this community. An interesting statistic that I put at the end is that an estimated 50% of America's population actually live in rural communities. So it's really important to address sort of the disparity that we see in service administration between rural versus urban spaces. This is just a summary. And again, you may, I think you have a reference, you have your own copy of this. You can also go through it on your own time. This is just kind of summarizing all the things that we talked about. So really just increasing awareness, understanding the importance of context, and as well as understanding that privilege and oppression are actually two sides to one coin. One side has advantages, meaning the other has disadvantages. So really want to reiterate that. We've also spoken so far about BIPOC women's experiences and how a lot of times there is a significant amount of bias, and that research that does sort of go and expand off of these challenges is primarily focused on BIPOC women occupying lower wage or more physically demanding jobs. Another one is emotional burden, racial weathering. These are things that we've sort of conceptualized so far in order to frame BIPOC women's challenges. And finally, research illustrates that there are so many contributing factors towards why there is a disparity of services being administered and service outcome within rural communities. So our personal experiences and identities, we are going to do some self-disclosure for a little bit. And I believe I am first. So this is a picture of my mom and I from Mother's Day this year. I do have one younger sibling, which is not pictured here, but she's in California. So shout out to Cleo. So a little bit about me. From the micro individual perspective, I am second generation Korean American. I come from a dual language household. I was born actually in Tacoma, Washington, and I come from a single parent household, and we did grow up religious. We went to church every Sunday. From the more macro community perspective, I do have higher education. I have a master's degree, and I occupy a white collar job. My professional identity within the community, I believe, is compromised due to both macro and systemic influences, assumptions, and values, which are evidenced through sort of biased treatment from clients, which I get into a little bit. And then from a systemic, more societal perspective, I am able-bodied, I am heterosexual, and I use she, her pronouns. And these are some of the things that I've sort of have been impacted and experiencing as a minority individual. So the Asian model minority myth that all Asians, have this amazing capacity to be successful, therefore, discrimination or sort of race-based conversations can't apply to those of Asian identity. I navigate a lot of stereotypes about, Asian women specifically being demure, unproblematic, submissive. So there's just a lot of intersecting factors that I come into contact with, not only in high school, but which also continued in my graduate studies. So I'm sure many of you know or can relate when you take the multicultural class in graduate school. I have to say that that was extremely traumatic for me. And, it didn't stop there. I interact with and am confronted with these biases a lot, I would say, when working with clients, as well as when I interact with my colleagues. I feel like oftentimes, based on my expertise and training, that's not really recognized or seen first. Usually what they see first is, an unproblematic, quiet Asian woman. So these are just some of the things that I've experienced in my field and that impact me.
Yeah, I was about to say, for one, I just love how Chelsea really just formed everything. And also, too, here are going to be some of my identities I will not be going over. But of course, right, if you have any questions for us, there is going to be a contact slide. And then again, we'll go over that again. But just wanting to be sure that everybody can always reach out to us too. And so basically, some of the things that I really wanted to highlight is that I am a first generation Latina and also too first generation college student, and also too growing up in a bilingual household, and also my parents were migrant workers. And so again, I really just like pointing out this picture too. And again, this was really a highlight of Chelsea's idea. But for me and myself, it has been kind of a hard journey and opportunities to actually kind of be where I'm at right now. And so, kind of the biggest thing with this is that actually I had thought it was my college orientation where we took this picture, like right after, but it was actually I had to take my math placement test. And so basically, I had to get up really early in the morning, take this test, and then right afterwards, we had to come back and help our parents. And so it was just this point where, for one, we are not ready to work in the fields. And for two, it was just this feeling of having to do what was right for me and then also to having to do what was right for my family. And so having both of those things at once. And so really I kind of think of the story of Atlas having to carry kind of the world on his back. For me, it felt like I was having to carry kind of two worlds on my back, with having to either go in between different languages, either having to go between, again, studying for college, but then also to going back and helping my parents. And now, again, that still kind of comes up with being a clinical supervisor and actually seeing like the disparities of people having an expectation of what I should be like. And then also to knowing that, again, like I do come from either humble beginnings or humble background. And so kind of pointing that out. And also to kind of wanting to highlight for myself as a clinical supervisor, I am the only woman on the team. And also too, I am the only person of color on the team. And so sometimes it does get, for one, really hard. Again, I experience weathering a lot, and also to even just the emotional labor of having to be there either for my colleagues or also to even for different staff. And also to all of our staff kind of approach us in different ways, either follow tasks in different ways, or also to just tasks are divided differently. So again, if you are a person of color in a position of power, for one, I see you, I feel you, and it is not easy. So thank you for all you do too.
Thank you for that acknowledgement. It's powerful.
Right? And I was about to say, Chelsea is also amazing with a lot of the different things that she's doing too, especially as being a staff in a lot of different things. So just throwing that out there. But also, another thing that we wanted to highlight is kind of contextualizing racial trauma and intersectionality. So you can actually see that there are a lot of different impacts that go into kind of BIPOC communities. So actually looking at mental health impacts, racial trauma that can be experienced, and socioeconomic impacts, and also to physical health. And these are some of the things that you even saw on our slides and how they all interact and overlap. And again, Crenshaw really had it right with a lot of different things.
So I'm just going to keep continuing to pick up the pace because I would like to have some time at the end. Does excess mean inclusivity? Not always. This is Dr. Anthony Jack, who is a scholar and author. And he kind of talks about affirmative action, which I'm sure you all are aware of, and how even if there is accessibility to services, that oftentimes services that are aimed towards specific populations aren't actually meeting the needs at all. So even if you do have access to a service, you still, that doesn't mean that you shouldn't carry out and do your due diligence of educating yourself, doing the research, what the needs are of the community. So does access always mean inclusivity? You found that not always.
So also too, we are going to go through some resources, but one thing we really wanted to kind of talk about is community. And so again, I'm going to go through these slides just a little bit quickly because we also want to get to some of the questions that you all have. So also too, this is again, just a short definition of what community looks like. One of the things that we did want to highlight is in 1986, McMullen and Chavez were actually able to kind of come up with the psychological dimensions of community. And they were able to kind of look at membership, fulfillment of needs, also to shared emotional connection and even influence. And also, again, you will have access to these slides, so you can always kind of look at the in-depth definitions that we have. And so one of the things that I really kind of wanted to highlight is community care. And so for one, with community care, it is taking care of others together. It is basically the foundation of togetherness. And also to community care is actually being able to use our power, privilege, and resource to better the people who are both in and out of our scope of reach. And so, of course, there is just a lot of amazing things that happen. And also community care is really just in the BIPOC roots, honestly. And so it's really kind of cool to see. But I know, just a side note, I know we're really kind of talking about BIPOC communities, but also wanting to highlight that, of course, right, culture is like so broad and in depth. So, of course, if community care can be anything, it can be like, hey, I really like my PTA meetings. I really like my Zumba class. I really like, again, just anything that you have going on in your life, church group, etc. That is actually participating in community care too. And it fills our cup almost a little bit differently than self-care, but it is still needed. And so also too, again, we're just going to go through like two things on this slide. And I do want to mention that with community care, there are so many different examples in US history. We're just going to focus on two for today. And so one of the things that I would like to highlight is just the curbside effect. And so basically in the 1940s and a little bit before, there were actually individuals who were in wheelchairs that were actually cutting the sides of curbs so they can get to the other side of the street. And so it was, for one, this huge thing that was happening across college campuses, also to across town, so that again, people with disabilities would actually have access. And so it is really interesting to note that in 1968, this was actually something that was being passed into law. And so again, if we really kind of think of community care, it took about 23 years for government to actually see those things. So just wanting to highlight that. Also, too, in the 1960s and 1970s, the Black Panther movement really developed a lot of different things. I wish, again, we had more time to really kind of go into this, but they were able to help with like different healthcare facilities, even just education access, and even food distribution. There was so much that they were actually doing. And there's actually a lot of different agencies that are kind of, for one, have used those routes to actually serve different clients and communities. So, again, wanting to highlight those two. And so now we're going to talk about some different helpful websites for BIPOC providers and clients. And again, this is just a disclaimer. Just because we have something presented on here, it doesn't mean that you will find it either worthwhile or something that really kind of sticks with your clients or for yourself. Again, they're just resources. If you're like, hey, this really doesn't speak to me, that is totally okay too. But we just want to at least give you more in depth of different things that you can't do. And a lot of these resources you can actually look to find actually different referral options, different community trainings, also to just different community boards to actually just interact with other either BIPOC providers or also to for your clients to be able to kind of get them connected. And so just throwing that out there. So here are some, and here are some more as well. And then also too, just wanting to throw this out there, some of you may have heard of this already, but the Mental Health Coalition, they actually have a whole list of all of the previous websites that we've already kind of talked about. And so it's really amazing to kind of go on there and kind of see what they have going on. Also too, all of the websites that were listed before just have like a really sleek design. So just throwing that out there.
Just some more resources specifically for BIPOC women providers. Here's two websites, Maine Healthline as well as inclusivetherapist.com. Maine Healthline hosts virtual meetings specifically for BIPOC women. And the above website is just a search site that's dedicated to streamlining inclusive therapists and resources, a good resource for clients and for yourself as a provider if you're looking for a counselor. And just know that you're not alone. Really make sure to go out and connect with those that you trust, build that rapport, and identify boundaries to help support your emotional health at work and at home. Establishing a self-care routine is paramount as well. And finally, self-validation. Pat yourself on the back and celebrate those small achievements and know that, again, you're not alone. This is a resource specifically aimed at rural health. This is a website where providers can log into and just sort of do trainings. And it's sort of like a toolkit for resources and skills, specifically when you're a provider working within rural health areas. And the second one is a really good one. It's a rural health mapping tool endorsed by the CDC, and it gives really specific information for different counties and different states. Since our agency, Triumph Treatment Services, is located in Yakima County, this is the example that I went with. You just select which state you're in and then county, select the topic, and then the information will be provided for you below where the third arrow is. So another really great one, especially if you're in rural health.
Most definitely. And also too, with this resource as well, you can actually look at different suicide rates specifically for your county. And so that could be really good to kind of just either look at the research or also to the data that is actually being done in your county too. So also as well, we do have other coping skills. And again, this is just a meditation. And so this is from The Pain That We Carry. And so with this book, it actually looks at IFS and using this with clients and also to actually kind of bringing in different identities. And so with this, we won't be able to go through it just in depth, but also I just wanted to give you just different examples that you can use. And so again, right, just making sure that you can have your clients as comfortable as they can be when they're with you. You can also do this if you just need a time to just check in. And then also too, with this, you're just going to kind of say to yourself, I breathe in healing, slowly exhale to yourself that again, I am releasing these cultural burdens. And so then I was able to kind of do this exercise for myself. And so some of the cultural burdens that I do hold is always having to feel like I have to be perfect or be perfect in kind of both languages. And so that is something that I release. Another way to look at this is that, of course, again, there is so many DEI tasks. I release that too, or hey, I need to take a break. So kind of keeping those things as well. And so again, with kind of looking at what to kind of give your clients or what they're wanting, really kind of explain this in depth to be like, hey, you can kind of give yourself self acceptance, confidence. But I think kind of one of the biggest thing that the book doesn't really go over is, of course, right, just kind of giving yourself space in professional settings, in college settings, in settings that have not been either the kindest to us or also to that are the biggest perpetrators of microaggressions. And so again, kind of giving your clients or also to yourself that. And so with legacy burdens, this is going to be any kind of personal burdens, but also to, for me specifically, some things that I was able to reflect on would be kind of letting go that intergenerational trauma and also to kind of either that perfectionism or also as well that I can't just be myself. And so again, kind of giving your clients that space or yourself that space. And another way to utilize this is that, of course, right, just having them actually go through the different messages that they've told themselves and kind of what that looks like for them. So kind of just throwing that out there as well. So here is another exercise. This exercise can be used with clients or also too for yourself. If you feel like for clients that are a little more introverted or also too don't want to talk in session, this could be a really good activity just so that you can actually see what are kind of the negative either messages that they heard, the negative programming, negative schemas, or also to negative self-beliefs. And it's in a way that kind of presents it as what was I hearing when I was younger and what is still there with me today. And so kind of seeing if anything's shifted, anything's changed, or of course too, right, kind of thinking about, again, intersectionality, critical race theory, or also to any of the other terms. Are they really still embedded in kind of this person and what will help them with letting go?
All right, so again, just a very brief summary, implications for best practice for all providers. First and foremost, we do want to highlight the call for research on more intersecting identities and the experiences of BIPOC women, specifically within healthcare. The biggest takeaway, I think, is just increasing awareness, acknowledging power differentials, and being willing to have those difficult conversations, right? So studies found that white counselors who discuss these power differentials they increase their alliance and credibility among BIPOC clients. Finally, validate, validate, validate. One suffering does not mean that all suffering is the same. I really want to emphasize the importance of validating and making that human connection through that validation. These are two very basic resources that anyone can use, not just BIPOC individuals. The Color of Fear is a really great film where different men of different identities kind of talk about different topics. The second one is Counseling the Culturally Diverse. Not only does it go through sort of understanding how to intervene and address clients that are different than you, but also clients who may look different than you, have different abilities than you, right? So really going across that spectrum of what diversity means and looks like when you're working as a counselor with those kinds of clients. So two really great resources I wanted to throw out there.
And also too, here are just some evidence-based treatment modalities for racial trauma. So again, we can actually look at CBT. There is a lot of different information and a lot of different books that actually look at, again, racial trauma and also to going through CBT. Also to CPT, a little bit similar, but of course there's going to be more of a trauma narrative. So kind of throwing that out there. IFS, again, The Pain That We Carry is a really good book, and it really looks at the different interventions of IFS and being able to present that with clients. Also to systems theory and then also feminist therapy. They actually can be really helpful with working with BIPOC clients and individuals. So just throwing that out there. And of course, DBT, EFT, and EMDR. And there is so much different literature and so many different books that you can actually pick up that look at this topic specifically. So just wanting to make sure that we do kind of touch on this as well. And so here are all of the references that we have. Let me tell you, it was an interesting time, but we are here now.
And thank you for joining in on this presentation with us. So like Stephanie said, it was a journey. I hope that you took away as much as we did during this presentation. So thank you. And again, our contact information is down there below for you.
Also too, thanks for choosing us. We know that there were, again, a lot of different sessions. And so we are so glad that we were able to actually call you today.
Thank you, Stephanie and Chelsea. What a fantastic, thorough presentation. Absolutely loved it. Thanks so much for sharing your personal stories and specifically being able to talk about racial trauma. I think that one thing I really appreciated was you sharing the resource of Mainline Health. We do have some questions here, and so we're going to go through those. You ready?
Yes.
Okay, let's go. How does the phenomenon of racial weathering impact BIPOC health care providers? And what strategies can be implemented to support their well-being and resilience in the workplace?
Oh, that is like such a good one. So
Juicy,
also
right?
too. Oh, what was that? Sorry.
I said juicy, right?
Yeah, I was about to say, Gina, you are making us put on our thinking caps right now. So also, I will kind of touch on this. It's really going to depend on, again, if you're in an agency setting, if you're in a private practice, also too, if you're just in healthcare, colleges, it's going to look a little bit different. But also the biggest thing would be is that, of course, right, kind of looking at just a simple thing you can even do right now, are tasks actually being delegated like more to BIPOC providers, or also to, is there an even distribution of work? And so that's a really good one. Another one could be actually checking in with BIPOC providers, but also too with white folk, right? So kind of checking in for burnout, seeing what kind of is going on, if there's any unique factors. If we can actually go back to the contextualizing race slide, you can actually see, right? Or again, racial trauma, that again, mental health, also to physical health, and then even kind of looking at just different identities. We want to be able to check into those things as well. So kind of going through that in supervision, or also too on one-on-one meetings to kind of see that. Also, if there are any other things that you're doing in your agency that really kind of highlight DEI work, that can also be good too. But again, making sure that things are a little bit more equitable in how we're distributing things.
I think the first part of the question is really interesting too. I know how the racial weathering impacts BIPOC. It impacts us significantly, right? If you can't provide the care for yourself, how are you supposed to give it to your clients? So I think, like Stephanie said, just checking in, and it can show up in so many different ways. I just wish we had more time to talk more in depth about it.
Right. So we've got time for one more, just about a minute. So here's this question. How can academic institutions and training programs incorporate BIPOC perspectives, I love it, and experiences into their curricula to prepare future behavioral health professionals?
Oh,
do you want me to?
I was about to say really quickly, I'll go through this in like 20 seconds. But also too, there are actually a lot of different things going on with the HCA and also too with different institutions, even in Yakima right now, that are actually looking at getting different BIPOC providers just insight. And so there was actually just a panel that was held about 3 months ago. So again, if you can actually just for institutions or also too for colleges, have those panel discussions and actually invite in BIPOC providers, hear kind of what their stories were like, hear kind of what their experience was like. And again, also to kind of keeping in mind that either for immigrant or migrant, just BIPOC individuals, there's going to be kind of some differences with academia, right? Just because, again, you have individuals that are either moving a lot. And so kind of keeping that in mind with curriculum, like, is there a way to actually include, just like we think about math, right? Like just different equations or different things like that they can actually review, because not everybody has the same educational background. So kind of keeping those things. And then Chelsea, I'll let you.
No, I think it's really good. And just making sure that the individuals in these programs that are facilitating them are taking the time to educate themselves on the resources. It's not the client's job to have to educate you about all this intergenerational trauma. It surpasses even it's politics, art, psychology. So just providing those resources for people to be able to say, hey, I took the time to read up on this. And I just want to say, and sharing that burden and collaborating really well with individuals in your community, I think is really key and important.
Most definitely. Also, too, I know there was a lot of questions. So again, you can always reach out to our contact information listed on our slides, because there was a lot of good information where I'm like, oh, that would have been amazing to actually answer. So
Thank you so much, Stephanie and Chelsea.